I am going to start talking about the formulary file, which is another file that you can use to supplement the PDE data, and you can request it separately as part of the Part D data. And I will talk about kind of what you get when you request these files, and then Gia is going to talk about an application of how to use the formulary files in conjunction with the PDE data. And then she's going to move into talking about combining Part D data with other utilization data, like A and B data that's fee for service, or A and B data that's encounter Medicare Advantage data. So with that, we can go ahead and get started. I will actually put in the chat. So some slides were not in the current versions. I apologize for that. We can update them on the course website, and then you'll be able to see the updated version. I'm putting that in there. I've checked to make sure all of the segments are visible, but please let me know if there's anything that you are not finding. So I apologize for that. Any other questions before I get started? Okay, I will then move into talking about the formulary files. So as I mentioned, the formulary files it's a suite of files, but when you're requesting it, you would say, I would like to request formulary files. And then you will get access to a few different types of formulary files. But you ask for, just formulary files. So what is a formulary? This is part of the benefit design of plans. They can cover formulary is basically a list of drugs that are covered by the formulary, but it also includes information on how they are covered. So for example, we talked about tiers yesterday, that there might be a tier that is designed to cover generics, and there's a tier for brands, or non-preferred generic, non-preferred brand. So a formulary includes the drug that's covered. It lets us know what tier it's on. And then based on that tier, you can figure out what is the cost sharing that a particular individual has. Now, there are formulary public use files. They're available back to 2006. And in those, you get a base formulary file and an excluded drugs file. So you can request those. They're actually downloadable. The most recent years, you can just go to the website and download them. But if you want previous years, you will have to order them, and then there's a fee that you would pay to get those. Now, we are mostly talking about the research identifiable files. That's what you would get if you went through ResDAC and requested these files. And we have them available from 2010. We have the base formulary file, the excluded drugs file, and the OTC drugs file. When you request the formulary file, you get all three of these. And in 2020, they added an indication-based formulary file. And then in 2021, Part D Senior Savings Plan formulary file, which we'll talk about. So for the PUF formulary files, as I mentioned, you can get these from the CMS website. These include the NDC codes, but they do not have generic name and brand name. That's something that you would have to obtain via linkage with another set of data. They do have the tier level that it is covered under. And then they have indicators for whether there's step therapy, quantity limits, or prior authorization. Remember, those are all ways that plans can kind of direct the beneficiaries to use the drugs in the way that they would like them to be used. And then you can, because these have the NDC codes, you can link these with unencrypted contract, plan, and formulary IDs. You can link them to the Part D RIFs and the MBSF, data. So because you have contract, plan, and formulary ID, you are able to link. And as I mentioned, there's a free download if you are interested in the most recent formulary years, but if you want to go back farther than that, you would just have to request the data and pay a fee to get those. There is not information on the therapeutic class. So unfortunately, that is the one piece that's kind of missing from our suite of files that has to be obtained somewhere else. And So I'll start with the base 3 formulary files. We have a base file, excluded drugs file, and over-the-counter file. We're going to talk about these each in turn. The base file is Part D covered prescription drugs. The excluded drug files they're prescription drugs that are not explicitly covered under Part D, but the plan may offer them. Remember, plans can offer enhanced benefits, or they may or may not be under a plan's enhanced coverage, but a plan may decide to offer a drug that's not, if a plan offers enhanced coverage, they're not under obligation to offer excluded drugs, but that's one way that they might enhance their coverage. And then we also have an over-the-counter file, and we'll talk about why that is, given that we have a prescription drug program. What you get when you are requesting the formulary files, it's at the formulary ID, it's actually at the formulary RX ID level, but you need to use both of these variables if you are going to be linking to the PDE. The formulary RX ID is drug specific, and then the formulary ID tells you which formulary this formulary RX ID belongs to. So a given drug, a given NDC code, can be associated with multiple formulary RX IDs because they might be on multiple different plans formularies. So you need to do this linkage. You can't just, link by NDC code, unfortunately, because what you want to know is for this particular drug fill, if you're starting with the PDE, for this particular drug fill, which plan's formulary is it on and how is it covered under that plan's formulary? So that's the kind of information you'll get from the formulary file. You also get the tier number, which again tells you kind of how the plan you have to use the tier number in conjunction with the plan characteristics tier file in order to know how that particular plan is covering that particular tier, but it does tell you the tier. And remember, most plans have 5 tiers, and so this will give you information on which tier this particular drug belongs to. Should an NDC belong to a single formulary RX ID? No. And the reason why is because, a particular drug is going to be covered under one formulary for Plan A, but Plan B has a different formulary set up. So they've got a whole formulary associated with them. So they have their own formulary RX ID for that drug. And Plan A has their own formulary RX ID for that drug. So that's why you end up getting multiple formulary RX IDs for one NDC code. For formulary files over years, I haven't tried to do it would be interesting to think about how to group them over time. One of the things that has changed is the tier structure. Most plans now have that 5-tier structure, but as the Part D plans have changed over time, the tiering structure has changed. So that is one thing that definitely has changed over time, I would say. But most drugs have been covered for all of Part D, but we'll talk about some exceptions with that. So it's just a matter of where they're going to fit into the plan's formulary has probably changed over time. And so you do want to make sure you're getting the particular formulary file for the calendar year of PDE, for example, that you're looking at. There is information on whether or not the plan has a quantity limit associated with this drug. So maybe you can only get 20 pills at a time for this drug. You'll have to come back and get a refill if you want more. Whether or not prior authorization is required, or whether or not step therapy is required. So that would be saying, we really want you to try this drug before you try the one that you're asking for. So this will say how many steps are required before you can get to this drug. And then we do have brand name and generic name on the RIF files. They weren't on the PUF files, remember, but if you're getting the research identifiable files, you get brand name and generic name, drug strength, dosage form. So for NDCs for the same drug but different dosages, will they have the same formulary ID and formulary RX ID? That I have to think about this. I don't know if I've looked at that particularly. I'm guessing they might have a similar formulary RX ID, but that's something that you might want to look at. So again, the formulary ID is unique for each formulary, and each Part D plan has decided on one formulary, but a particular formulary could be used by more than one plan. So oftentimes plans, as we mentioned yesterday, kind of work with pharmacy benefit managers that are putting together these formularies, and they may share their formulary with more than one plan. They may sell that package to more than one plan. So the total number of formularies is not the same as the number of plans. In 2021, there were 557 formularies. You can see it's just increased over time. The formulary RX ID is, sorry, I have this on here. It's unique for a single drug, which is the brand name, strength, and dosage form. And it can be found, you can find the same formulary RX ID in different formularies as well. The number of formulary RX IDs in one formulary has, it's increased over time, the average. It's not, it's been around 3,500, but the maximum has definitely increased. Some formularies have, 6,000 formulary RX IDs, and the minimum has increased as well. So the minimum number of RX IDs on a single formulary is 2,400 in 2021. So there are drug event records that can't be linked to the formulary file. It's not common, but why would this happen? You might say, I don't understand how this prescription was filled, but we don't have the formulary information for it. Sometimes First Data Bank or CMS, they couldn't identify the NDC code for the drug. The NDC code just doesn't match anything that they had. So CCW was unable to create the RX ID value. Or sometimes a beneficiary could ask for a drug that's not on formulary. They could appeal and ask for it to be covered by a plan, even though it's not in the formulary. So then you would see a prescription fill for it, but it wouldn't appear on the formulary. So that might be a reason that you would see a PDE fill that you couldn't link to the formulary file. And then it could also happen that the formulary changes over the year. The file represents what is included at the end of the year. So if a drug had been paid for earlier in the year and then was deleted, these are created at a point in time, the formulary files. So sometimes you wouldn't be able to match those. And then there was a question about whether drugs covered by Part B have formulary information in the formulary file. This is really only drugs that are covered under Part D, paid for by the plan. So that's what you would find. I think. Okay, so thank you. I think I've got most of the questions. When we looked at how different therapeutic classes might show up in the formulary file, because there are some missings, you can see that there are some therapeutic classes for which it's very rare to have missing formulary RX ID. You've got penicillins, antifungals. The therapeutic classes that we most often didn't see any formulary RX ID for the selected class: vitamins, antacids, alternative medicines, multivitamins. These aren't showing up in the base formulary file for that year. And we can talk a little bit more about what other checks you might want to do if you don't find something in the base formulary file. Utilization management in the RIF formulary files. For the base and excluded drugs only, we get information on utilization management. So this includes the tier ID. So that's one way of, directing patients to particular drugs, is to say, we'll cover that generic drug with a minimal copay, but if you want the brand drug, you're going to pay a coinsurance or a greater copay. So based on tiers, they can kind of steer people in a direction. Also by requiring prior authorization. So if pre-approval is required before coverage, that's another way that or that plans will use to change how someone might use the drug, essentially. Just making sure that the drug is being used appropriately. Quantity limits, again, they might say, we will fill this for 20 pills and you'll have to come back for a refill or come back and get a new prescription if you want more, or step therapy. So how do these look in the file? And we should note that the data sources used by CCW are the health plan management system. The plans will submit, and then CMS has one health plan management system that kind of covers all of their bids, and it shows kind of their benefit packages. There's the PDE plan contract and benefit package. That information can be used to be brought into the formulary file, the plan formulary. And again, this is an end of the year snapshot. So sometimes you may see variation where something might be missing and you'll see it. You won't, you'll see a missing value, but it's just a mismatch with timing. CCW is not able to match all event records, again, to either a formulary, but it's depending on the year, we've got about 2.5% to 8% of PDE records are going to fall into either not applicable or unable to link to plan or null. So if it's null, you don't have information about whether the NDC didn't link to the formulary. You just know that it can't link to either the plan or the formulary. For the tier ID values, the one thing to keep in mind is that each on the formulary file, you get a tier ID value for each RX ID. However, that doesn't necessarily tell you how the plan is treating that tier. So in order to get that information, you would link back to the plan characteristics tier file, because although most plans, have this 5-tier structure, and the first tier might usually be preferred generic or non-preferred generic, it's not always. So you should go back and check. The majority of plans are now using this 5-tier structure. This is an older graph from MedPAC, but I like it because it kind of shows how things have changed over time in kind of the early years, where there used to be fewer plans with a 5-tier structure. Sometimes they would just have a brand versus generic. And then now we've moved into much more 5-tier structure. And this stopped at 2014. And the latest MedPAC report that came in July 2023 analyzed these files and found that, and the plan files found that almost all plans are using this 5-tier structure. You will see values of 6 for the tier ID. And that's a new tier that's kind of, I think it's mostly vaccines. So you will see that, but just 5 is essentially the bulk of drugs are going to fall into one of 5 tiers. And so I did include the 6 here, but it's, a small amount. When we look at how the PDE records are falling within tier ID value, and we link PDE to the formulary file, in 2009, most were in the first tier, but most plans had maybe a 1 or 2 tier structure. Now that we have most plans having a 5-tier structure, we see more spread. And tier 5 is often a specialty tier, but it doesn't always have to be. So again, in order to find out what the tier means, you would want to link back to the tier file. So again, there's prior authorization indicators, and those will say whether the drug is subject to prior authorization or not. If it's 0, however, it could either be that the drug is not subject to prior authorization, or the plan is not required to submit a formulary. So it's not like, sometimes you'll see 0, 1, 9 if the plan wasn't required to submit, but in this case, they're lumped in with the 0. So just be aware of that. But it does mean that there's no restriction on the drug. And about 1 to 2% of PDE records are identified as needing prior authorization. For the quantity limit, 1 indicates that there are quantity limits. 0 is that there are not quantity limits. We don't have further information on how it's being limited, but almost a quarter of PDE records did have quantity limits associated with them. And then the step indicator, it will give you the maximum number of steps that's required to get to the drug. So so step by steps, I mean, what else do you have to try before you can, or how many other drugs do you have to try before this drug will be filled? And so it's the maximum number. It's not necessarily, depending on if there were two different step therapy protocols for the product, there might be different numbers associated with it, and we get the maximum here. If it's a blank, it is not. It maybe doesn't need step therapy, or the drug is on step 1. So there are no step 1s. 1 is never the maximum number. It just means if it's blank, that means it's on step 1. You can just get the drug without getting any other drug, or the plan is not required to submit a formulary. So again, there's not a lot of drugs that are required where step therapy is required, and most of the values are going to be either 2 or 3. Now we're going to talk about the excluded drug formulary file. So this is this will be a subset of formularies that are included on the base file. So all of the formularies on the excluded drug file are also in the base file. So it's one formulary per plan, remember, and they may have drugs on this excluded drug formulary file as well as drugs on the base file. But the setup is essentially the same. You have the formulary ID, formulary RX ID, same variables. And you can see the number of formularies that have excluded drugs in 2021 was 99. The number of excluded drugs per formulary in this file was 7. So much smaller than the base file. One thing to note, in 2012, the most frequent drugs on the excluded file were benzodiazepines, and then in 2015, it's erectile dysfunction drugs. I looked in 2021, it's still pretty much erectile dysfunction drugs. So why do you think that change happened? Does anybody have any quick guess? This is just, it's one of those things where we have a policy that's changed. So when the Part D program first started, benzodiazepines were not included as the Part D covered drug. There was evidence that, you know, they're related to falls and possibly cognitive impairment. And so if you were looking at erectile dysfunction drugs in the data, you might find that they haven't changed over time. If you look at benzodiazepines, you might find that use was lower prior to 2013 when a decision was made that they needed to be covered, right? So 2013 was when the benzo coverage was added. That is how, but erectile dysfunction drugs are still not covered by the Part D program. So, but plans can cover them at their discretion. So just something to note. You might see, you know, like I said, if you were looking over time at benzodiazepines, you might see use really increase in 2013, and you might think, well, that's curious. And that will lead you back to looking at the policy. You might look into the excluded file and try to understand why, if you were using the formulary file, you would see that benzodiazepines were not included on that base file. Oh, so can you talk about how does Part D decide which drug to cover and how the drugs belong to each tier? So it's actually 2 separate questions. Deciding which drugs to cover programmatically, the Part D program covers most drugs. There are a few classes like erectile dysfunction drugs that are excluded, and that's really a policy discussion. It happens at the policy making level. In terms of whether a particular plan decides to cover a drug or which tier it's going to be on, that will be how the plan, usually the plan is working with a pharmacy benefit manager, or they may have it in-house, but they're doing calculations to figure out, you know, will this enhance our coverage enough to get more people enrolled in our plan? What is the cost going to be to us? Can we afford to cover this drug? So that will be on the plan level, and it will vary by plan. When we look at the difference between the base and excluded in terms of utilization management, we get a lot more utilization management, actually, like prior authorization and step therapy. And this is, I had mentioned before that when we looked at the PDE ID, not a lot of drugs required prior authorization. Or so when we were at the PDE level, at the formulary level, it looks like more drugs are requiring authorization. This is at the formulary RxID level. So this isn't drugs filled, this is just drugs covered. But then, and there's step therapy that's required for drugs, for covered drugs. But once we get to the excluded file, it's most common that there would be quantity limit versus other utilization management. And I think that's just a fact because of the types of drugs that are being covered under each. And when we look at the tier structure, excluded drugs, are more likely to be kind of in this tier 1, which is probably a generic tier, but we would want to link back to the tier file to figure that out. And then this is just kind of shows how the structure is different for base and excluded. Now we have this over-the-counter formulary file, which again, over-the-counter drugs and OTC, I should say, is over-the-counter. They're not part of the prescription drug program because prescription drugs and over-the-counter drugs are 2 different things. So, sorry, one question was, why does the base and excluded have such differences in prior authorization and quantity limit? Again, I'm guessing that it's probably a difference between the types of drugs, and I would say that a plan that's deciding to cover a drug in the excluded file has probably already determined that it's worth their while to cover it in terms of cost, so that they're not going to try to dissuade someone essentially from filling that prescription. Whereas in the base file, these are sometimes drugs that they have to cover, and so they may have try to make sure that people are using it as appropriately as possible because it costs them money to cover it. Hope that's helpful. So again, with our OTC file, we have very similar, very similar information, although no utilization management variables. Again, because if the plan is offering OTC, over-the-counter drugs, it's probably part of their utilization management scheme, but they're not going to restrict access to these drugs. So again, prescription drugs and over-the-counter drugs, 2 separate concepts. However, the prescription drug program may cover them if they want someone to use the over-the-counter drugs. If they want them to use them instead of a more expensive prescription, for example, then they would cover them. If it's the first step in a step therapy program, they want you to use Tylenol before they're going to cover Tylenol with hydrocodone or something like that. They want you to try the over-the-counter drug first and then move into the prescription drugs. So there is on the plan characteristics file, you can see whether or not they're using over-the-counter drugs as part of a utilization management program. So that's one indicator you could look at. That's on the plan file, not on this formulary file. But the drug formulary file, OTC drugs, do show up here in the OTC formulary file. If you found that indicator, you could look in this file. The most frequent drugs, antihistamines. So, get the over-the-counter allergy medication before you try the prescription. And then what is the reason first data bank appears? Why not Multnomah or other proprietary sources? I actually, I don't, because CCW is the one that creates the data file, it's the one that they decided to make a contract with, and I don't have the the background information on why that one was chosen, but and then we have 2 new files. This one was new in 2020. I apologize, Gia, I'm going to go just a little bit over. We have the indication-based formulary. I will say that this is new in 2020. It's interesting because this is a new CMS policy in 2020, which says that plans can restrict drugs to only FDA-approved conditions. So previous to that, if a drug was on the formulary, it could be covered for any condition. Now plans have the ability to say, we're only going to cover it if it's for FDA approved conditions. And there are 2 new variables on this. This is also at the formulary RxID level, but we have two new variables. One is the mesh CUI. This is a standard alphanumeric code, but we also have the disease variable, which is the text, which essentially just tells us, it labels what the mesh CUI is. The number of unique mesh CUIs on the indication-based formulary is 9. So it's covering 9 distinct conditions right now. Sorry about that. And there's only 2 formularies currently on this. So the number of formularies that are associated with each one of these individually is only 1. There's 1 formulary that's covering anxiety disorders, and there's 1 formulary that's covering, anxiety disorders and major depressive disorders. That's 1 formulary. And then there's another formulary that's got all of these other conditions on it. The only plans that I found that were associated with these formularies were the local coordinated care plans. This hasn't had a ton of uptake right now. This policy has not, as far as those, but it is a newer policy, and this is 2021 data is the most recent that I had. I don't know in more recent years how it's been used. There's also the Part D senior savings model, which the goal, this was new in 2021. So the last year of data that we have is the first year of data that this was available. The goal was to provide stable and predictable copays for those with particular insulins. So the maximum would be $35 a month, so that someone that needed insulin would know they could plan on having a particular copay every month. If you want a list of the insulins that are included by NDC, you can click on that link. And for the copay would be unchanged through all of the phases, so you would know how to plan this, I should say. For this file is in the formulary file suite, but it is actually at the contract plan formulary ID level. So it doesn't have, or formulary RxID. It doesn't have a formulary ID. It's just got the plan and the contract, which you could figure out which formularies. But this is really a program that's being conducted at the plan level. There are 227 contracts participating, which is 1,505 plans. The number of unique insulins that are covered per plan is 25. So you have a wide variety, and you can tell what kind of insulin it is. There's a variable called type, which would tell you whether it's combination, concentrated, intermediate acting, long acting. So interesting information in this plan, but it's pretty new. So, or in this file, I should say.